we're moving on to things that cause atherosclerosis. We're into dysfunction now. So the main things that we're going to talk about are atherosclerosis and heart failure. There are two parts of atherosclerosis, and that includes hypertension and hyperlipidemia. You could have one or the other, or both, and frequently people have them together because they do tend to amp each other up. The first part we're going to talk about is hypertension. So this first part of the lecture corresponds to the slides that talk about cardiovascular dysfunction. So there's the first picture of the proper way to take the blood pressure, and what you're measuring is the systolic blood pressure, which is the highest amount of pressure. That's the time that you have the volume in there from systole as well as the peripheral vascular resistance. And then the diastolic blood pressure is a measurement of the vessels during diastole, which is when the heart is at rest. So you should just be measuring the resting resistance of the vessel, not resistance plus a volume that occurs in systole. So you'll see as you get into your track classes and start to actually see patients that the recommendations for what hypertension is and how you should treat hypertension is based on national guidelines. And in terms of hypertension and coronary artery disease and heart failure, those guidelines are from the Joint National Commission. The last one's developed in 2017. And there are some controversies about those guidelines because they are much, much tighter than they used to be. If you look at the stages of hypertension at that slide, it shows you that elevated is 120, 129 over less than 80. And stage 1 hypertension is actually 130 over 139 over 80 to 89, which was typically our pre-hypertension, or what was previously known as that. Now, there is some debate about whether or not we should be as stringent about these recommendations. In fact, the American Heart Association is on the fence about how much we want to, or aggressively we want to treat people's blood pressure. And I do think it depends on the age of the patient. So if you're concerned about syncopal events or blood pressure being too labile, then maybe you need to work with it a little bit differently. But if it's a younger person and you're worried about really their future destruction of vessels, then it's probably appropriate to start thinking about treating sooner. So, but you'll read different people's opinions about that as you get into your track classes. Hypertension, primary hypertension is really thought to be multifactorial. A very complicated interplay between genetics and lifestyle. There is some kind of overactivity of the sympathetic nervous system and renin-angiotensin system. The increase, especially when discussing weight, the increase in obesity-related hormones can also increase sympathetic nervous system and renin-angiotensin output, as well as increase insulin resistance and inflammation in the vessel itself. So for every 6 pounds of fat, you actually do increase hormone output from that fat and increase the amount of insulin resistance and obesity-related hormones released, which can be vasoconstricting and prothrombotic. So the best thing that anyone can do in this situation is to lose weight. It has the greatest impact on the person's blood pressure. So then there's kind of a complicated slide there with some arrows, which I sort of simplified for you here. And really it's the genetic factors, obesity, and overactivity of the sympathetic nervous system and the renin-angiotensin system that leads to sustained vasoconstriction and fluid retention, which means sustained high blood pressure. And just like when we talked about in the first class, when there's an increased stimulation of some kind, when there's increased stress, the body has different ways of adapting to that stress. And increased stress, increased stimulation, one of the ways the body adapts is by hypertrophy, which is what the vessel will do too, under this increased stimulation. And that eventually will lead to vascular remodeling, where the At first, that muscle layer of the vessel of the artery becomes hypertrophied and then begins to change and become more fibrotic and harder. And so thus less likely or less able to change in terms of the local environment and have much increased resistance, decreased radius, affecting flow to the rest of the system, which is what causes our end organ damage. So there's a very nice picture you can see there of the extent of vascular remodeling that can occur. There's a picture showing you that a vessel with that middle layer is kind of abnormal. One side is thicker than the other, but that tiny, tiny little open area in the lumen is what is left for blood to flow through. And that's what leads us to our end organ failure. And so there are some pictures there to illustrate what end organ failure looks like for the person. So that kidney on the upper left-hand corner, the nice beefy red kidney that because of loss of tissue and ischemia is smaller. Hypertension will decrease the amount of available nephrons. The change in vascular changes to a person's foot leading to ischemia, changes in the brain, loss of brain volume, changes in the eyes. All those things occur because of hypertension. The next contributing factor to atherosclerosis can be hyperlipidemia. And to understand this, we first have to look at how lipids are made in the body. And there's a video attached in the Moodle site that shows the lipid metabolism as well. Most people who develop hyperlipidemia in this country is related to lifestyle, is taking in more than you need. There are some people that have genetic hyperlipidemia, and that has to do with the amount of available receptors to take in the lipids appropriately, but that's not very common. Usually the issue is the intake itself. And you do need cholesterol. It's not as though we don't need lipids. They are part of all cell membranes, so they are essential for repair of cells, and they are part of any steroid hormone. Those are made of cholesterol, so we do need cholesterol. It's just that we take in more than we need. So when you eat a meal, this is your esophagus, you go to the state fair, you have your sandwich that is 2 donuts as the bun and then the meat or whatever. All that fat goes into the small intestine. The first part of the small intestine shares circulation with the liver in a special portal circulation. That is where your triglycerides and cholesterol will be absorbed and go to the liver to be processed. The liver will produce very low density lipoproteins, low density lipoproteins, and high density lipoproteins. These are different in terms of their percentage of protein and percentage of triglycerides and lipids. Very low density lipoproteins have a very small percentage of lipids, a little bit more triglycerides and protein. Chylomicrons, which I did not list at first, are really primarily triglycerides. Low density lipoproteins have the high percentage of lipids and a lower percentage of proteins. And high density lipoproteins have really very minimal lipid in them. They're actually mostly protein. These chylomicrons, very low density lipoproteins, and low density lipoproteins will go to cells in order to share their cholesterol triglycerides for maintenance or production of hormones. What's left over, which hopefully is a small percentage, will be taken care of by the high density lipoproteins, which I like to visualize as sort of little Roomba vacuums in the blood vessels. And that's kind of how they're like little open cassettes that will kind of scoop up and get rid of excess lipids. Whatever's left over should either be scooped up by HDL or hopefully recycled through receptors in the liver. And that would be the healthy way to manage our lipid metabolism. body has used the cholesterol it needs, and HDL has returned what it can. Whatever is left over will be taken up by what's called the scavenger pathway. The scavenger pathway uses macrophages to get rid of what circulating lipids in the bloodstream. So macrophages will phagocytize the lipids, and we know how macrophages work. They engulf what is either foreign body or foreign material that doesn't belong where it is, and that will fuse with its lysosomes, which will then kind of chop it up. And for this, that means that the lipids are sort of come out and fill the cytoplasm of the macrophage, and that is what's a foam cell, is a macrophage that's just full of fat. That foam cell is kind of heavy. It will collect at the endothelial layer and start the process of building a plaque. If somebody has hypertension or smokes or has some other reason that they would have endothelial injury, then this process is easier. So if the person has hypertension, there's constant friction of blood as it goes through that vessel under high pressure. So it can actually cause injury to endothelial cells, making it easier to deposit foam cells in a vessel. And so that's why oftentimes people will experience this condition together, or it certainly would make, having hypertension would certainly make hyperlipidemia changes to the vessel worse. Now we have this deposit of foam cells, which is called a plaque. The body tries to seal this off, so there will be growth factors released to increase the growth of endothelial cells to cover this foam cell in an attempt to sort of stop the plaque from gathering together, to try to wall it off. The body always likes to wall off things that aren't supposed to be there. Because that happens, we certainly have decreased the lumen at some point in the vessel. This decrease in the lumen is irregular and is not like the sustained change in the size of the lumen related to peripheral vascular resistance. So many times students will decide that having plaque build up in your vessels will cause hypertension, which that is not true, because this is irregular. It's not all the way through the vessel. What this does is cause turbulent blood flow, which can lead to cracks in the foam cell from friction, or could lead to activation of platelets if they come out of the central circulation. So you can develop a clot here. And that's really the problem with hyperlipidemia. It's not an increase in blood pressure. It's a change that can lead to the development of clot, or if this keeps getting bigger, could potentially close off flow itself. So if you think about a coronary artery that might have might have lipid plaque here, that then suddenly the person develops a clot and they have a heart attack, or suddenly this closes off, or when they're trying to increase their activity, can't get enough oxygen to the muscle. That's the problem we would have together. However, certainly people can have hypertension and hyperlipidemia together, and together they do contribute to atherosclerosis, or hardening of the vessels. And together, because most people have this, they contribute to a change in the amount of flow and oxygen-rich blood the person can get. These conditions together will severely decrease the radius of the vessel, but in two different ways. One is increasing the size of the media through vascular remodeling, and that's hypertension. That's the increase in the size, thickness of the middle layer, the media, or the muscle layer of the artery. And this is sustained and throughout every vessel, leading to decreased flow and increased pressure on the vessel. Whereas hyperlipidemia, the media layer, that middle layer, isn't affected. It's the intima that's showing the plaque, showing that some portions of the lumen will be irregular. And if the two of these exist together, you certainly have an increased problem with flow.